Hi, I'm Rami Kumrokji. I'm the Vice Chair of Malignant Hematology Department at Moffitt Cancer Center and Professor of Medicine. It's a great pleasure to be here in Brazil at the Brazilian Hematology meeting, a very well attended meeting. During my tour here, I've been discussing myelodysplastic syndrome and its management and treatment, focusing on lower risk myelodysplastic syndrome. So myelodysplastic syndromes, as known, are the most common myeloid neoplasm. Anemia in elderly is a common problem, and MDS is one of the top causes of anemia. And really, we've made progress in diagnosing MDS. The classification had been revised. We have now newer versions emphasizing molecular entities. The risk stratification had improved, incorporating molecular data with the integration of IPSSM. But more importantly, I think we've made progress in the lower risk MDS by having newer treatment for patients. I think the first point I try to make is obviously treating anemia is important in lower risk MDS. We have clear data to emphasize that red blood cell transfusion dependency impacts overall survival for patients and associated with worse outcome. This is a reflection of the biology of the disease, but also the complications of blood transfusions. So treating anemia is important. And anemia is present in 90% of MDS patients, and over time, half of the patients will become transfusion dependent. And transfusion dependency is associated with worse outcome. So even what we consider a lower risk MDS, once those patients become anemic, the median overall survival for those patients, unfortunately, is 3 to 4 years. And there is a lot of data also correlating anemia with worsened quality of life, impact on cardiac function. I think we are moving forward to start treating anemia more, and maybe in the future not even wait till patients are transfusion dependent. So in that context, for example, in our group at Moffitt, we looked at our patients in lower risk MDS, and we looked at the natural history for those patients. So first, most of the patients that are lower risk will stay as lower risk. 60-70% will never progress to higher risk MDS or AML. However, unfortunately, majority of those patients will die from complications of the cytopenias. And then we looked at the responses of those patients to treatment. So we took a group of patients that never had progression of the disease, that got erythroid stimulating agents. So the responses were around 40%, which is expected in the literature. Then as second line, only half of the patients went beyond erythroid stimulating agents to get a second line therapy. And in that group, only 1/3 of the patients responded. What was really eye-opener for us is seeing that beyond the second line of therapy, third, fourth line, irrespective of the treatment, less than 10% of the patients respond. So this emphasizes that we need to treat anemia earlier in lower risk MDS. We need to think of active therapies to move them up front, and we need to think of transplant actually in younger patients once they have 2 or 3 lines of therapy failure. The last 2 years had witnessed improvement in the management of lower risk MDS. So we have at least 2 newer drugs in the USA approved or the label expanded. First, luspatercept, which is a TGF-beta pathway drug. It's a fusion trap protein that neutralizes the ligands of the TGF-beta pathway that control the terminal erythroid differentiation. So luspatercept was originally approved in patients with ring sideroblast after ESA failure based on a study called the Medalist. And now the label had been expanded to allow upfront treatment based on a study called the COMMAND study. So in the COMMAND study, patients with lower risk MDS were randomized between receiving luspatercept versus erythroid stimulating agent, and the study showed that luspatercept doubled the erythroid responses as well as the duration. So now the standard of care is changing, where patients with lower risk MDS with anemia would receive luspatercept as a first-line therapy, particularly in patients with ring sideroblast positive. We also had another drug in the United States approved called Intelistat. This is a telomerase inhibitor approved as second line in patients that are highly transfusion dependent, and hopefully in the future it will be available in Brazil as well. And we are also making progress, obviously, in more understanding the MDS. Targeted therapies are coming down the road, like IDH inhibitors. But overall, I think we really should think of lower risk MDS as a disease that does impact patients in terms of survival, in terms of quality of life, and the treatment is important. There is a lot of efforts also looking at drugs that target the inflammatory pathway. So there is a lot of exciting ongoing studies. One of the studies also to highlight is the ELEMENT study. This is a randomized phase 3 trial that's looking at patients that are not transfusion dependent to be randomized between luspatercept and ESA with the goal of looking at the time to transfusion dependency. There are other compounds also in the TGF-beta pathway like elritercept that are being looked at after ESA failure. So the field is really evolving, and it's exciting time, and I'm very happy that we can provide more options for our patients. So thank you very much for having me here in Brazil.